Meet Mr. Ellis. 68 years old, 2 days out from a hip repair and, until this morning, an unremarkable recovery. But overnight, something changed. His temperature has climbed to 38.9, his heart is running at 118, his breathing is quick and shallow, and his blood pressure has slid to 92/54. He is suddenly confused, not himself. His urine output has fallen off, and his lactate has come back at 4.2. One patient. 6 decisions. Over the next few minutes we are going to walk the exact path the NCLEX wants you to walk. The clinical judgment model. One careful step at a time. Let's begin. Step 1. Recognize the cues. This is where every good decision starts, and where a rushed nurse goes wrong. Before you treat anything, before you even form an opinion, you have to see what is actually in front of you. So slow down and scan the whole picture. The vital signs, the mental status, the labs, the trends, the timeline. Some of what you see is just the ordinary background of a post-operative patient. A little pain, a little grogginess, and some of it is the body quietly sounding an alarm. Your job in this step is only this: to separate the signal from the noise, and to notice everything that matters, without yet deciding what it means. Look again, and pick out the cues that count. Take your time. Open the Vital Signs tab and read them as a set, not one at a time. His temperature is 38.9, up. His heart rate is 118, up. His breathing has climbed to 24, up. And his blood pressure has drifted down to 92/54. 4 arrows, and they point the same way. A body under stress, the heart racing to hold up a falling pressure. Any one of these, alone, you might explain away. Together, they are the early signature of something spreading through him. Now the Labs tab, and one number here does most of the work. His white count is high, the immune system already mobilizing. But look lower, at the lactate, 4.2, and rising. Lactate climbs when the tissues are starving for oxygen, when perfusion is failing down at the level of the cells. A lactate above 4 is not a mild abnormality. It is a red flag for serious hypoperfusion. Set that number beside the fever and the low pressure, and the picture stops being vague. Here are the cues that count. First, a new fever, 38.9, that was not there yesterday. Second, a heart rate of 118, with fast, shallow breathing, the body trying to compensate. Third, a blood pressure of 92/54, and drifting down. Fourth, and this one is easy to miss, new confusion. In an older patient, a change in mental status is often the very first sign that something is seriously wrong. Fifth, a urine output that has dropped, the kidneys already feeling the lack of flow. And sixth, that lactate of 4.2, a number that tells you the tissues are starving for oxygen. Any one of these, alone, you might explain away. But you do not treat them one at a time. You hold them together, because together, on a post-surgical patient, they form a pattern. Those are your cues. Step 2. Analyze the cues. Recognizing a finding is not the same as understanding it, and a cue only means something in context. So now you take everything you noticed and you sort it. One column for what fits an ordinary recovery from surgery, and one column for what is a genuine red flag. Some incisional pain? Expected. A little drowsiness lingering from the anesthesia? Expected. But a brand new fever, a climbing heart rate, a falling pressure, fresh confusion, a rising lactate, those do not belong to healing. Line them up side by side, and ask the question that turns a pile of data into a clinical picture. What do these add up to? Sort them out, and the picture resolves. The incisional pain and the early drowsiness fall cleanly into the expected column, the normal aftermath of surgery. But everything else lands under red flags. The new fever, the fast heart, and the low pressure together. The new confusion, and that lactate of 4.2. Now look at what those red flags represent. You have a source, a fresh surgical wound. You have a whole body inflammatory response. The fever, the racing heart, the fast breathing. And you have organs beginning to fail, the confused brain, the low pressure, the falling urine, the climbing lactate. A source, plus a body-wide response, plus organ dysfunction. That combination is not a coincidence, and it is not post-op normal. That pattern has a name, and naming it is the next step. Step 3. Prioritize. You have gathered the cues and you have analyzed them. Now you must commit, because you cannot act on everything at once. Out of all the things that could be going on here, you name the single most likely and most urgent problem, the one that, if you are right, drives every action that follows. So weigh the possibilities honestly. Could this just be post-operative pain? Sedation from the opioids he received? An expected, harmless low-grade fever? Or is this something that will not wait for the morning? Do not hedge. Put one problem at the very top of your list. The priority is sepsis, progressing toward septic shock. Here is the reasoning. Sepsis is not just an infection, it is infection plus organ dysfunction, and this patient has both, the confused mind, the falling pressure, the rising lactate. And a lactate of 4.2, together with a blood pressure this low, is not early, quiet sepsis. It is telling you that shock is close. Pain and sedation are real, but they do not explain a fever, a lactate of 4, or a failing blood pressure. They are the distractions a tired mind reaches for. The moment you name sepsis as the priority, everything sharpens, because sepsis comes with a clock. There is a 1-hour bundle, and the sooner you start it, the better this patient does. So we start it. Step 4. Generate the solutions. Notice that we are still not acting. First, we lay out the options. This is the select all that apply step, and the skill it tests is whether you know the whole plan, not just one piece of it. So think through the sepsis bundle deliberately. What genuinely belongs? Blood cultures, to find the organism. Antibiotics, to kill it. Fluids, to restore the pressure. A lactate you will trend, to see if it is working. And just as important, what looks reasonable but is actually wrong here? Treating only the fever and reassessing later? Or holding fluids to spare the kidneys? Gather every appropriate action, and leave the traps behind. Here is the appropriate set, and the logic behind each. Draw blood cultures before the antibiotics, because once the drug is in, it can sterilize your sample, and you lose your one chance to identify the organism. Give broad-spectrum antibiotics within the first hour. Every hour of delay in septic shock raises the risk of death. Begin a 30 milliliter per kilogram fluid bolus to refill the vascular space and lift the pressure. And measure and trend the lactate, your objective marker of whether perfusion is recovering. Now the traps. Giving an antipyretic and waiting until morning treats the thermometer, not the sepsis, and wastes the hour that matters most. And restricting fluids to protect the kidneys does the opposite of what you want. The kidneys are failing from too little flow, and fluid is the fix, not the threat. Step 5. Take action, and now the order becomes everything. You have the orders in hand and the plan in your head. The question is what you do first, second, and third. You already know a key rule. Cultures come before the antibiotic, so the drug does not contaminate your sample. But you also know the antibiotic cannot wait, so drawing those cultures has to be fast. Then the fluids, running wide open. Then the reassessment that tells you if it is working. Sequence these interventions the way you would actually carry them out at the bedside, and notice how the reasoning from every earlier step feeds this one. Here is the order. First, draw the blood cultures. It takes under a minute, and it must come first. Second, immediately after, hang the broad-spectrum antibiotics, so that obtaining those cultures never becomes an excuse to delay the drug. Third, start the 30 milliliter per kilogram fluid bolus, running fast, to restore perfusion. And fourth, recheck the lactate and the mean arterial pressure, your evidence that the plan is working. Cultures, antibiotics, fluids, reassess. That precise sequence, cultures before the drug, but the drug without delay, is the difference between a nurse who is treating sepsis and one who is merely documenting it. Now you act, and then you watch. Step 6. Evaluate. This is the step students forget, and it is the one that closes the loop. You acted, now you have to find out whether it worked, because the patient's response is what dictates your next move. So 1 hour later, you gather the very same data you started with, and for each finding you ask a simple question. Is it better? Is it the same? Or is it worse? Did the fluids lift the pressure? Is the lactate trending down? Is his mind clearing? And most importantly, is anything still failing despite everything you have done? Because if it is, you are not finished. Here is the reassessment, and it is a mixed picture, which is exactly the point. The good news first, the lactate has fallen from 4.2 to 2.4, improving, perfusion is recovering, his confusion is lifting, the brain is getting what it needs again, improving. But now look closer, and stay honest, his urine output still has not recovered, unchanged. And here is the finding that changes everything. After the full 30 milliliter per kilogram of fluid, his mean arterial pressure is still stuck at 60. The fluids helped, but they were not enough. A blood pressure that will not hold after adequate fluid resuscitation is the very definition of septic shock, and it names your next action. Start norepinephrine and titrate to a mean arterial pressure of at least 65. And that, from the first glance to the next intervention, is the full arc, all 6 steps of clinical judgment on a single patient. Let's tie the whole case together in one picture. Your cues: a new fever with a fast heart and fast breathing, a blood pressure of 92/54 with new confusion, a lactate of 4.2, and a fresh postoperative source. Your action: the hour 1 sepsis bundle, in order, cultures, then antibiotics, then 30 milliliters per kilogram of fluid, then reassessment, and norepinephrine the moment the pressure would not hold. And the outcomes you are steering toward: the source treated, perfusion restored, the lactate clearing, and the shock reversed. Recognize, analyze, prioritize, generate, act, evaluate. 6 steps, 1 patient, every single time. Now the next patient, on chemotherapy, and he spikes a fever 38.5. But here is the trap: almost everything else looks normal, and his white cell count is nearly gone. He looks, for all the world, fine. And that is precisely what makes him one of the most dangerous patients on the unit, because a body with no white cells cannot mount the response that warns you. 6 decisions again, and the very first cue is the one almost everyone underestimates. That is case 202.